So it's the four pillars of personal injury case management. And again, it's used for not only your treatment protocol, but again, as I stated, your deposition reports and narratives and deposition and testimony. And remember when we talked about personal injury attorneys and the personal injury market itself, we talked about the statistics that show from the Insurance Research Council that 87% of the patients have a connective tissue injury. So by far, the connective tissue injury is the largest injury. And the second one was the disc injury at roughly 32%. So 2/3 of the people in an automobile accident do not have a disc injury. And then we talked about the peripheral neuropathy, as much as 16%, and a mild concussion at 10%. So using those as the criteria and the statistics, we're going to make sure that we stay focused on the majors and not the minors. And it's easy when you go to personal injury seminars or impairment ratings or thing like that. And I remember it's very easy for them to talk about really peripheral stuff that in all likelihood you'll never see in your life practicing, and they'll spend like hours on that. That is not what we're doing here. It's really gaining a very simplistic understanding of the processing of the personal injury case. So relative to the personal injury attorney, so we talked about the need, establishing the need, because remember 75% of the personal injury attorneys do not quarterback or refer out their case. And remember, only 32% of personal injury patients see CAM providers, complementary alternative medical providers, of which chiropractic is the highest, but that says 68% do not. So you have this huge, large segment of opportunity, and we talked about the difference of attracting them, of using advertising versus educational sales. And that's not to be talked about here. But the point being is from the personal injury standpoint, we're talking about the need versus the primary and secondary service factors. And again, the goal here is not to talk about primary and secondary service factors. But the reason I point that out is after all these years of practicing and opening offices and being in the field, I found that there's three competitive advantages for the chiropractor. Three. Relative to the market forces. Obviously, number one is there's a tremendous amount of business that the chiropractors aren't seeing. That's the 75% of attorneys who don't refer out, and then also the 87% of the connective tissue injury, and 2/3 of those people, 68% of those people, are not seeing chiropractic providers. So there's a tremendous opportunity there. But there's three major areas to compete that I found that the chiropractor can really stand out. And I've pointed this out on several occasions. Number one, and if we let me just back into it. So if we look at those major injuries, what's the likelihood that a chiropractor is going to compete with a medical doctor? And when I say compete, I guess I'm going to qualify that and say credibility. And I'm going to say from a jury standpoint and from a personal injury attorney standpoint. So I guess I'm not saying clinically, so don't get involved clinically here when I say compete just yet. So when we look at the 10% mild concussion, what's the likelihood that as a chiropractor's credentials is going to be able to compete with another healthcare provider, such as a medical doctor, neurologist, etc.? Well, you're not, unless you hold some type of specialty or there's some type of extra networking you have. But I'm just talking apples to apples, nothing unusual that you've done as a chiropractor per se, like you haven't authored a book or anything like that. So just be aware of that. Secondly, so that's the mild concussion. So is that a position that you're going to be able to compete? No, you're not going to be able to compete. The neurologist and the neurosurgeon and the medical providers, especially in that particular field, will easily have more credibility than you, the chiropractor, in the brain injury category. So let's go up to the next category now. Can you compete with a peripheral neuropathy? So remember we said about 16% of auto injury cases have the peripheral neuropathy. Are you going to be able to compete with a neurologist and electrodiagnostic testing? In other words, is what you say and do going to bring more credibility and authority to the case than the neurologist and third-party high-trust electrodiagnostic testing? No. even the interpretation of it, it's going to be the neurosurgeon, just because that's the way it is in the United States culture and society. So, and again, I'm just saying if things are normal. I'm not saying that you have this great record or you authored a book or you're, a chiropractic neurologist. I'm not talking about, exceptional things. So is that a position, the market? And remember, we're talking about marketing. Where is your optimal position from a marketing standpoint? So let's go to the next category, which is the disc injury. So how is the chiropractor going to compete with the disc injury? Well, they're not. You're not going to compete with a radiologist, a medical doctor, radiologist interpretation of an MRI and a disc. The chiropractor, let's face it, the medical doctor, radiologist is going to have way more credibility if things are even in a court of law deposition. So that's not an area of competition also. So let's come up to the connective tissue. That's where you can compete. Unfortunately, your target market is in a state of unconscious incompetence. They don't know the value. And most chiropractors don't know the value or how to interpret and present, in other words, market that value. So the connective tissue injury. So 87% so by far of all the injuries, it's the connective tissue injury. Well, let's go ahead and how does that relate to the healing process relative to other healthcare providers? Well, how can you as a chiropractor compete? Remember, I'm talking about relative to a deposition in court of law in front of lay people on the jury. That's when I'm talking about compete. I'm not tied into emotionally being connected to chiropractic. I'm talking about from an objective standpoint as the culture and society sees it. So from the jury standpoint, are we going to have anything special or unique to compete in the inflammatory phase of treatment? In other words, to use anything in that category for our marketing? No, we're not. There's many of other healthcare providers, and a matter of fact, the way medicine is today, that medicine is way better branded than natural, or way more people use medicine and accept anti-inflammatories and muscle relaxers as normal, way more than anything else in the U.S. culture. So we're not going to be able to compete therapeutically in that category. Now, are we going to be able to compete in the repair phase category? Yes, we will. Because remember, in the repair phase categories, the three is when we're impacting the scar tissue and the collagen, specifically the three ranges of motion. And there's no other healthcare provider that actually has the therapeutic protocol to affect the collagen fibers in the healing process in all three ranges of motion: active, passive, and joint motion. There's no other provider. And that is a very competitive niche or segment. And it just so happens that 87% of the patient base has a connective tissue injury. So we not only are the best in that category, uniquely positioned, but it's the largest category. But the problem remains, it's two problems. The target market doesn't understand, in state of unconscious incompetence, there's not a perceived need. So it takes very effective educational sales, not advertising. And typically the provider doesn't know how to do it. And so that's where the incongruency occurs. Now, when you go to the third phase, can you compete? In other words, win in the remodel phase relative to other healthcare providers? Well, no. Physical therapy is well known for rehabilitation, for affecting strength and mobility. And from a pure credibility standpoint, the physical therapist naturally has greater credibility than the chiropractor. So we're paying attention to where the segment of the market is, where you can compete, where's your competitive advantage, and how big is that market? Well, fortunately, it's a very big market. Fortunately, you got a couple things to your advantage. Number one, you're the only healthcare provider that can essentially not only treat all three phases, but going vertical in the repair phase. You're the only healthcare provider that can go vertical. Now, that's a cognitive concept. That's not a marketing concept. I'm just explaining to you cognitively why and how to position yourself as we do. So number two is you not only have the ability to treat all three phases. Well, that's not a competitive advantage. The competitive advantage makes you because you have the ability to treat all three phases and specifically cover the second phase, all three phases, which happens to be the number one largest injury that happens, and it's mostly overlooked, the soft tissue injury. So that's from a competitive. Now, having said that, there's three major areas of emphasis that the chiropractor has a very good competitive advantage. And number one is the soft tissue AOMSI, or, and people forget this, / altered intersegmental mobility. That's a highly competitive diagnosis and treatment protocol, because that's what you do. You treat, the chiropractor treats in that repair phase all three ranges of motion affecting AOMSI and altered intersegmental motion. And again, on a separate video, I talked about after the pathology, you may not have enough data from a quantitative standpoint to qualify for an AOMSI, altered spinal motion, as stated by the AMA guides. That does not mean you do not have a permanent pathology. The diagnosis becomes altered intersegmental spinal mobility. It's not per definition. And so when you take that category, and remember, there's way more people. If you just looked at altered movement, there's a way larger percentage of people that will have altered intersegmental mobility than will have AOMSI. But now when you combine both of those together, you really have a very large percentage of people with a soft tissue injury. And if you think for yourself all the patients you've treated, you know, and after 16 years of treating patients, I tell you, I don't think I've seen one normal motion x-ray of a spine. I mean, when you see a static normal x-ray, it's kind of shocking to look at a static x-ray that's normal. It's like, wow, that's unusual. But then when you do a dynamic study, a flexion extension study, it is very rare to see static and dynamic motion studies. Well, that's the soft tissue. That's the soft tissue that holds those joints together, that allows for aberrant motion. And that's strictly from Biomechanics of the Spine, Panjabi and White. That's an orthopedic neurosurgeon and a research scientist. And that's the name of the book, Biomechanics of the Spine. So AOMSI, inclusive of altered intersegmental mobility, is a huge potential because it affects a tremendous amount of people who are injured. It's a large portion of the injury category, and we're the segment niche that not only has clinically the ability to treat it, but also to cognitively demonstrate it, objectively and quantify it and objectify it in a court of law, a jury. So that is that is absolutely the number one position where you, as the chiropractor, should be positioned in your language, in your talk, in your marketing, in your process. That's number one. When you try to compete in all these other areas, you're going to lose. So I found there's three areas, but overwhelmingly that's one. Number two is the actual case management presentation. I've found over the years there's not many doctors, even personal injury doctors that say they practice personal injury, that know how to put the case together sequentially. And that's what we're going to cover right now, is the 4 pillars that you have to cover for your personal injury case management. That is what the case is based on in every way. So there's not many, they know I found there's bits and pieces, but to have the total congruency of connecting all those dots, all 4 of those segments together, I haven't found very many people that are very good at that. So that's the second value proposition, is the case management presentation of connecting the dots. Now that's hard to say. In other words, it's a hard marketing concept to say, but it's an easy concept to experience. And that's part of what happens in the personal injury attorney sales presentation. That is one of the major byproducts of that presentation. It's not just establishing need, but it's showing that attorney, you know what you're doing, and you know how to connect all 4 pillars and make it cognitive for the lay jury and win this case. So that is another, but it's a difficult, in other words, it's hard to say as a value proposition, I can give a better case presentation than that guy. Okay, see that? So it's very difficult to say that directly It's almost experiential, and that's what that presentation does. So that's the second category. So I wouldn't necessarily be saying it from a marketing USB, unique segment position, but I'm going to be delivering it. They're going to experience it. That has tremendous, tremendous value when the attorneys can see that you know how to do that. The third factor is understanding the 3 phases of healing, specifically in these categories. Number 1, as it relates to any restrictions, limitations, or inhibitions. Restrictions, limitations, or inhibitions. In other words, do you have the ability to explain the 3 phases of healing relative to that patient's restriction, limitations, or inhibitions in 2 categories? Impairment. In other words, now explain why that is an impairment. Okay, that's number 1. Number 2 is future care. Can you explain, based on the 3 phases of category, why this person is going to need future care? Now, that's very important. And in particular, we're going to put emphasis on this, especially when you go into the duties under duress and lifetime enjoyment activities. Can you explain why this person has pain or discomfort picking up their child or rolling the bowling ball when they have absolutely normal gross range of motion and normal pain or discomfort with just standing and moving around? Can you clinically, scientifically explain that? Well, that's what the 3 phases, an understanding of the 3 phases of healing does. It gives you the ability to connect all these dots. So those are the 3 major areas that you have tremendous value from a competitive advantage dealing with the personal injury attorney market. And that's where I would be focusing a lot of my attention in my communication and marketing. Now, let's go into the 4 pillars here. So the 4 pillars here, and remember we're talking about the 80-20 rule. And the 80-20 rule, again, is we're talking about the core. We're not going to worry about that one injury you may see in a 30-year career. That's not what we're talking about. We're talking about those 4 injuries. We're talking about the connective tissue injury, the disc injury. We're talking about the peripheral neuropathy, and then the mild concussion. So that's essentially, and then if you get the basics of processing and connecting those dots, it's of tremendous value. So here we go. The 4 pillars of the personal injury case management are number 1. Number 1. Now there's a lot of smoke and mirrors. Again, there's a lot of smoke and mirrors that will confuse you. In other words, the defense will typically come after you in one of 4 categories, and typically all 4 categories. They will try to attack you, your knowledge and skill level and what you've done. They'll try to they're going to either try to diminish or reduce your credibility. They're going to try to attack chiropractic's credibility. They're going to try to attack any objectivity. They're going to try to minimize any objectivity relative to your diagnostics, and definitely subjectivity. That'll just be destroyed. And then the next one is they're going to try to minimize that this injury caused that amount of a problem. They're going to try to minimize that there's no way that this little bit of an injury could have caused that much of a problem. Those are the 4 categories they're going to come at you. Now, there's a specific sequence of how to handle that, but that's not what this is about. But be aware, when we process the personal injury case, we're going to include from day 1, from the consultation, not just the 4 pillars coming through, but I'm going to pay attention to the 4 angles of attack on how I'm going to get attacked with this case down the road. Those are the 4 angles of attack. They're going to attack you. They're going to attack chiropractic. They're going to attack the objectivity of the case, and they're going to attack the magnitude of the accident couldn't have caused that type of injury. So I'm actually going to build into my case evidence from day 1 in the consultation to counter their attacks 6 months, 2 years from now. But that's not what we're talking about now. But I want you to know that that is what we will do, and we need to be aware of that, okay? So let's go into the 4 pillars of case management. Number 1 is you have to be able to connect the dots. Did this accident cause that injury? And you need to be saying without equivocation or on a percentage basis, what percentage did it increase that particular injury that may have been pre-existing? But you have to say, did this cause that? That is, you have to say it in your narratives, reports, depositions, and a trial. You have to say that. This caused that. Now, that's why it's real important when you take your history, and most of you take pretty decent histories. That's why you pay attention to a lot of these questions, and I call it kind of looking from inner to outer, and that's why you get answers to questions such as um, looking at where the person was positioned in the car, front seat, driver's seat, rear seat, whatever. Where was their body position turned? And again, what we're looking for there is were any joints locked out upon impact. Also, was there a chance to respond? Did they see the impact and brace for it, or did they not? Because that's going to affect your defense mechanisms. You're obviously going to have a lot more injury. If you're not ready, that's kind of like a whiplash. If you're not ready and you get slammed, there's all that energy is going into all that tissue as opposed to you being able to protect yourself first. So all of these series of questions we're going to be paying attention to, and let's just cover some of the majors. So the body positioning, the angles of the anatomy to see if joints were locked out. What anatomy impacted what first? Did it impact something else second and third within the vehicle? So you want to know the collisions. What did you hit first, second, third? You're going to want to know what material was what they collided into. Was it soft material? Was it a hard steering wheel? Was it glass? Was it so? Not just what you collided into, but the material, and also from the inside, obviously the restraints definitely decrease the amount of deaths, but they skyrocket the injuries is what happens with the seat belts. And remember, the two aggravating factors are seat belts and alcohol and intoxication. You're going to want to know this and document it, because even if they were drunk with no seatbelt, you're going to want to say this before they say it, so you help minimize the impact. Because the worst thing you can do is not document it, and then you get clubbed over the head in a deposition or testimony that's something that you didn't even know, and you based everything on a supposition or knowledge you weren't aware of. So it's not advisable to ignore information that will minimize or hurt your case. That is not, and I see that a lot too. Don't do that. So there's a way of addressing it. There's a way of handling it and minimizing the damage to your particular case, so to speak. So we're talking about the position of the person. What did they hit first? What did they hit second? What was the position of the anatomy? Were they guarded? So those are some kind of internal factors, seatbelt, etc. And I typically kind of think from inside to outside is how I kind of always relay it. So what kind of vehicle were they driving relative to the weight of the vehicle and safety features of the vehicle and airbags, etc. Where did they get hit, front, back, left, or right? Did they get hit multiple times or just once? And then also the common things are, and not only the weight of your car versus their, because it gives you an idea of force. Remember, mass times acceleration is force. So if you have an idea of the size and mass of that vehicle versus another vehicle, that is another factor. Let's face it. If the patient was turned and the joints were locked out and there was no guarding and they're in a small vehicle and they got hit by a large vehicle, those are three major factors that will hugely impact the soft tissue injury. So being a somewhat of a decent detective of all the normal factors is very important, and being able to convey that information. So as we continue to go out, not just the size of the vehicles and where they were hit and how many times maybe the collision occurred, but obviously road conditions. And most people aren't familiar with road conditions, that actually if the road is slick or ice and there's an impact, there's actually more force imparted into the participant, where if it was stationary, there would take an X amount of force to get the vehicle to move first before that energy was, in other words, a certain amount of energy would be dissipated before it was transferred into the occupant. Most people aren't aware of that. So moving collisions are much worse also. So you can see how you can start to add these up. Well, what if we have joints locked out, we have differences in masses and the speed ratios, and we have no guarding, and it's on wet surfaces. Well, all of this is going to matter. This is going to have a major impact on that soft tissue. So these are some of the major factors to consider. And most of you have these in your information sheets, but that's the interpretation. So did this accident cause that injury? Number one, pillar. You have to be able to describe that. So that's where the good history of the mechanism of injury is very important relative to the personal injury case management. Number two is to objectify and quantify the injury. Obviously, subjective complaints are not very good. Now, they are supportive. I mean, I like to have the subjective and along with the objective because it helps solidify the case, but subjective complaints by themselves are not very good. So you need objective results. Now, you not only need objective, but you need objective results that are what are called third-party trusted. So if you're using some type of equipment, a classic example is like a chiropractic neurocalameter. Well, that is not a accepted diagnostic tool in the medical industry. And that, in other words, we have to use the standards that they use, because that's where the trust is. So you never want it to be about you. That's why everything you do, you want it to be a third-party trust that is accepted by the community at large, because that can't be challenged. And that's a classic example, using a neurocalameter versus that is not a accepted medically diagnostic tool. So that's, you can be very careful about some of these peripheral chiropractic diagnostic tools versus in medical industry standard. And let me just tell you, after practicing 16 years and opening 77 offices, you don't need anything wacko relative to chiropractic. Just stick with the industry standards that is accepted in health and medicine today, and you will easily be able to do very well in personal injury. So you don't have to deviate into anything unusual that's not accepted by the majority, that the defense can easily bring somebody on and diminish and attack you and your credibility because you use something that nobody even knows. So now that will relay over into every aspect of what you're doing. So that's why I never used anything that was not industry standard in medicine. So objectify and quantify. So obviously objectify and quantify. So we objectify. Now, so let's talk about what are the main objectifying tests. Well, if we got the injuries, we got the connective tissue injury, we got the disc injury, we got the neuropathy, we got the concussion. Let's go backwards. Let's start with the concussion. If there's any signs or symptoms of a concussion, then the recommendation is you as a chiropractor to not be and act as the radiologist. My suggestion to you is, if you have in your history, in your diagnostic protocol, signs or symptoms of a concussion, refer them out to get a neurological consult on the concussion. That's how that is handled. That's how I suggest you handle it, instead of trying to do it all in yourself. By the way, you'll have way more credibility, and also the personal injury attorney will appreciate your medical team, not you trying to be everything. So that's how that's handled. So same with a peripheral neuropathy. Same thing. You have signs and symptoms of a peripheral neuropathy. Do you have to be the neurologist and explain the axon dendrite synapse? No, you don't, and you don't want to. So that's a classic scenario also for a neurological consult. That's your medical team. So that's part of your medical team that you should have connected and networked and put in place, and just have gotten a neurological consult relative to a peripheral neuropathy, because chances are you're not the expert in that also. And it brings you way more credibility. So we move up the ladder to the disc injury. Well, most of you are pretty comfortable, with disc injuries. I found most chiropractors don't read MRIs, and you don't even have to. You just know how to interpret the MRI report. But remember, 2/3 of the auto injuries do not have a disc injury. So one of the things that I'm going to consider with the disc is I will consider factors that will help me in objectifying that lesion, such as stress MRIs, flexion extension, or MRIs with stress. And that's why, standing MRIs are good, or even flexion standing MRIs. That's why these motion well, they're not actually MRIs in motion, but they're dynamic stress. They're stress. Take the joint and stress it. Well, you'll help to accentuate and resonate and show greater objectivity. So I'd pay a lot of attention to stress MRIs, and it's very easy to call down to your local MRI center, talk to the radiologist, and ask some of the factors that they do to help accentuate such a stress MRIs that you can order. I don't know if you're aware of this, but you do not have to just order a default MRI. You can ask for specifications, like with the number of slices, the regions it covers, the angles that the default MRI may not have that you want. So, but again, we don't want to go off too peripheral here. You don't have to go and find and look for really obscure things to do very well in personal injury. And I see that a lot. Doctors are trying to go for, this one little unique thing over here, this whiz bang over here that's so rare and rarely happens, and they think that's what their marketing is going to be about. And I totally disagree with that. It's understanding the core of the process. So that's the diagnostic disc component. And there's nothing wrong with not, being able to interpret an MRI. And just reading the report. You'll know how to read the report, and calling over and asking the radiologist, the MRI radiologist, say, hey, this is what I'm looking at. What potential type of MRI, or how do you think we might position this to accentuate the lesion? So don't accept that you just have to do a default, okay? So that's the disc lesion as far as objectivity. And remember, up to this point, how much of this has really occurred? How many of these injuries are really out there? Well, only 32% disc, 16% neuropathy. So in other words, the vast majority of people are not going to have a neuropathy. The vast majority of people are not going to have a mild concussion. The vast majority of people are not going to have a disc injury. So now we're up to the connective tissue injury. And that's where the vast majority of the injuries. And let's face it, and I say this all the time, if you definitely understand and know how to manage from the connective injury tissue standpoint, you will almost always be included with the case that does have the disc injury or the neuropathy and a mild concussion, because what's the chances that a patient's going to have a disc injury, a neuropathy, or a mild concussion and no connective tissue spinal disorder? That's going to be very rare. I can't even think of how that would happen. I'm sure there's a scenario. So, in other words, the gateway. What is your way in? So the gateway is not to try to compete with people who are perceived as much greater value than you to try to get into the market. That is not the way to compete. It's to go in with what you're unique and special at doing. Unfortunately, it's a huge market. And then when you do, and that's kind of what happened with me, and then after they see you know how to manage and process the case, that's when they start sending you all their disc injuries and neuropathies. In other words, all these other bigger cases that they don't really think they need you because they have the orthopedist and the MRI and the neuropathy, and they've shot past the connective tissue component. That's not even on their radar. So that's how you can backtrack into these higher cases, come in with the connective tissue where it's massive and there's smaller amount, and they add value not only amongst themselves, and that's the majority, but they add value to all these other cases that they would use a medical radiologist or a neurologist, the attorney would use. Well, now they will include you because now they trust you, know you, like you, and they've seen your connective tissue injury work, and you add another dimension to that case. So that's how to position it and think about it, in my opinion. So we're talking about the connective tissue. So that is the objectivity. That's the objectivity. Those are the main, that's the 80-20 rule. Okay. Are there other factors to consider that are, secondary financial drivers? Sure. If you got a bruise on the neck or shoulder, sure, take a picture of it. Okay. So there are these secondary factors of financial drivers. There certainly are. But again, this is not a financial driver webinar. We'll do that later. So we're really talking about the main course of processing the personal injury case and how to interpret it. So those are essentially that's the objective. So we covered the first pillar, was definitely making sure that you can connect the cause and effect of the injury, number one. Number two is objectifying the injury and then quantify it. You also want to be able to measure it. And we talked about the importance of third-party industry standard objectivity and quantification, not the chiropractic stuff. So you get to the third one, which is the therapeutic protocol. And that's really two-sided. It's why you're doing what you're doing. So the therapeutics and the treatments, etc., it's totally based on the three phases of healing. So your therapeutic protocol. Well, again, you can't be challenged. You're not going to be challenged with the three phases of healing. That's the industry standard. It's the medical standard. It's the universe standard. That is the standard. Nobody's going to be arguing with you on the physiological facts of the three phases of healing. Now, how you quantify and objectify it, that might be another, or the results, that might be another issue. But those are the biological facts of life. And so that's why it's used. And that's why we used it also. So it can't be challenged. So the therapeutic protocol is why are you doing what you're doing? Or what are the therapies you're using to decrease pain and inflammation? If it's in that phase, if they're in the repair phase, what are the therapies you're doing to affect the ranges of motion? And remember, they do overlap. So I could still be trying to affect pain as I'm in the repair phase, trying to maybe start doing some passive mobility or things of that nature. So they do overlap. It's very easy to communicate these. So that's the why you do what you do. And of course, the outcome. The outcome is if there's permanency as a result of that. But also it's important to do your benchmarking. And of course, the benchmark for comparative analysis is for progression and MMI. So the benchmarking, the common benchmarking, obviously that's the re-exam with the subjective and objective re-exams. And then how does the functional capacity test play a role? That's the Roland-Morris Disability Index, the Neck Disability Index, the Oswestry Index. These are common indexes. Those are functional capacity indexes. And so these are good for benchmarking. They're to support your therapeutic protocol and the need for care. That's what those are for. Those are functional capacity indexes. They're not injury drivers. Okay? They're not injury drivers. Are financial drivers. So the financial drivers, the primary financial drivers are the specific injury diagnosis, number one. Number two is if there's an impairment rating. Number three is loss of enjoyment of life. Number four is duties under duress. Number five is the prognosis. So those are the financial drivers. So you do want these indexes to play a role because they're part of benchmarking and substantiating care and limitations or restrictions, okay? So be aware, if you're not using them, I do suggest you use those. Same with the pain diagram. Those are standard personal injury benchmarks. And so that's the therapeutic protocol. Remember, you're putting this case together. This is how you do case management, not only therapeutically, but from a narrative report, deposition, testimony standpoint. This is exactly how I'm putting it together. I'm connecting every one of these four pillars. So the next one is permanency. And of course, permanency is you're talking about you're going to relate all of those. In other words, you're going to relate the cause and effect in the permanency. And of course, that's based on the three phases of healing and how did the patient respond relative to the benchmarkings and do comparison, contrast, pre and post re-exams, etc. with the final exams. So that is what is supportive of the cause and effect with permanency. And obviously, you want to quantify, you want to objectify and quantify that injury in its permanency state likewise. That's why after there's MMI and there's no greater improvement, we will do that diagnostic test that shows that injury as at its final stage, such as motion x-rays of the neck at the end. Well, at the end, I'm not taking them to see if there's ligament laxity. Now I'm taking them at the end to see if there's altered intersegmental mobility. So, and to document permanency. So these are the benchmarks. And of course, we're talking about MMI, maximum medical improvement, when there's no more improvement. And that's based on your state definition. But MMI is essentially based on the three phases of healing when there's no subjective or objective improvement. Generally, it's considered a year. It depends on your definition by your state. So, and it's also an opinion, as close as you can get to that. So these are the considerations relative to permanency. And then, of course, you're going to want to explain where there's restrictions, limitations, or inhibitions relative to these activities. What activities are we talking about? Well, we're specifically talking about the duties under duress lifetime enjoyment activities. Now, they're indirectly related to activities of daily living indirectly, but they're not exactly the same. In other words, an injury is totally irrelevant if it doesn't impact a human life. So you can have an injury, and if it doesn't impact a human life, it doesn't matter. Remember, that's the difference between an impairment and a disability. An impairment impairs a functional capacity, where a disability limits or restricts a work activity. And a disability is an administrative function. Any administrator can give a disability. Only a physician, generally speaking, can give an impairment rating. And again, that's by definition of your state. But those are the two differences. So we want to pay a lot of attention in the last stage, which is the permanency. And again, what are we doing? We're totally relating this to the 3 phases of healing and the benchmarking. Are they at MMI? And then I'm going to pay a lot of attention of relating the benchmarking relative to the restrictions or limitations of duties under duress or lifetime enjoyment activities, which also means future care. Because remember, a couple of the major components in soft tissue injuries, so 2 of the main financial drivers is not only the rehabilitation care, that's a major financial driver for a soft tissue injury, but it's future care. Those are the 2 major financial drivers, so to speak, without dealing with surgeries and all, injections and all kinds of other stuff, generally speaking. So your ability to explain from a scientific standpoint, so now you have it. You understand the 3 phases of care. Your therapeutic protocol was based on each. You benchmarked accordingly, not only with your re-exam subjectively and objectively, but with your functional capacity indexes. And then in your narrative reports, just as you would in a deposition or trial, you'll do a comparison contrast of those benchmarking in your narrative reports. What was it then? What is it now? What was it as we received treatment? What was the end result? And then, of course, you're going to give your summary, your opinion. What does that mean? What does that mean? What was it? How did it change? What was the end result? And your opinion. Why is that a permanent injury? And of course, you should be able to explain that with knowledge of the 3 phases of healing, especially altered biomechanics. So that takes care of the need for future care. So just a couple points relative to duties under duress lifetime enjoyment activities. And I recommend highly, now remember, those are permanency statements. So when are they given? They're given at the end of care. They're not given as benchmarks. At the end of care, when they're at MMI, there's no more subjective or objective improvement. That's when they're given. Now, I recommend highly that you educate your patients, because remember, when patients are walking around with normal range of motion, with normal activity, and they don't have any pain, well, they're not going to fill that out properly. So you got to be really educate them, because the majority of the injuries, remember, are at overpressure, connective tissue injuries. They're at overpressure. They're not with active ranges of motion. Typically, active ranges of motion clear up. It's with overpressure. So you specifically want to talk to this person and go into their lifetime enjoyment activities. In other words, make sure you itemize through and go through and say, find out what it is that they specifically do relative to these activities, and interrogate them specifically if they do or don't have a problem relative to that, because they won't remember. They won't remember if they only have pain or discomfort, bowling, when they're lifting the ball and bowling it, or what have you, versus just a normal activity with no pain or discomfort with gross range of motion. They won't remember. They'll put on there, I'm normal. And essentially what they'll do is they'll stop bowling. They'll stop that activity because it didn't happen to any large degree to where it really impacted them, like if you lost an active range of motion. So I really put emphasis on coaching these people and getting into and finding out what their activities of life are specifically, and specifically putting emphasis and awareness into the overpressure. In other words, when they're lifting or or with excessive stress in whatever it is category they're doing. That's where you're overwhelmingly going to find your positive findings with connective tissue injuries, overpressure. So you got to take their consciousness there. So I do recommend that you do a little consult before with them and interrogate them to bring their consciousness up so they fill it out correctly, instead of just ignoring some, an activity that they had some discomfort with that they did periodically and then they just kind of stopped doing the activity. Well, no, that's a positive finding. That needs, let's face it. Would you want to not be responsible, the victim of an accident, and then have to limit something in your life, the rest of your life? Well, that's a compensatable injury. So those are the 4 pillars, and so that's how it would be reflected. And then based on those dynamics of your therapeutic, the injury and the objective injury, the objectification of it, your therapeutic protocol, and your benchmarking, you should be able to give a very good explanation of future care based on the 3 phases of healing and pathology. And so there you have the 4 pillars of personal injury case management, not just from a clinical standpoint, but also from an administrative standpoint when you put your reports together. So essentially, that is how your reports and narrative should look. You should just document all the mechanism of injury, what happened, why, pointing out these things. Then you should also include your objective, include your subjective, but also know it's not going to carry a lot of weight, but it will correlate with the mechanism of and the objective findings. So it's a supportive tool, making sure you identify all your objectivity and include comparison contrast, your benchmarks. And then after you give a benchmark of, the range of motion was this when they first started, and then it was this, and then it was this, and then it was this, give your explanation in why. In other words, tell why. And you should be able to do that with your knowledge of the 3 phases of healing relative to that injury. And you should have had the proper protocol of treatment relative to the 3 phases of injury. And it makes total sense. So that's you objectified it. That's how you objectified it. Your therapeutic protocol was totally based on that. You should be able to explain physiologically the different modalities and treatment and what you were trying to do relative to where that patient was in their state of care, in their state of healing. And then, of course, you documented all of them with benchmarking and your functional capacity tests. And then your permanency. And then explain, what they couldn't get back to normal. You should easily be able to relate the mechanism of injury to the objective test, the quantification of that test, the benchmarking that you showed, ranges of motion, x-rays, pain diagrams, whatever. And then you should easily be able to give an explanation of why that's a permanent injury based on the 3 phases of healing and what pathology that causes and why they're going to need future care. And those are the 4 pillars of personal injury. Last point is, I'm often asked, when should I do a test? Because obviously, depending on what state you're in, depends on, what's covered. And so a lot of times doctors will say, well, should I do the MRI? When should I do the MRI? Should I do an NCV? When should I do the MCV? And there's really 2 answers I give to that. Number 1 is, if it was your mom, what would you do? That's number 1. In other words, from a clinical standpoint, if it was your mom, what would you do? Would you not do the test? Would you do the test? Okay, so that's really the clinical. If it was somebody you highly cared about, what would you do? Would you sit on it or would you go get it done? Number 2, but that's not the answer by itself, because you do have to consider these other financial factors. Let's face it, time and money is an issue. So the other factors that I'm taking into consideration here is talk to the attorney. So many doctors don't talk to their attorney. Talk to the attorney. Let him know what you have. And talk about, what the case is, what's available, what are the limits, the financial limits. Talk to the attorney. Say, let him know what you have objectively and what you can show and where you're at. Find out where they're at relative to the money of the case and what's going to be covered and what's not. And from there, you should be able to make a pretty good decision if you do need to test, if you don't need to test. Do you need to take it to another level, or you really don't need to take it to another level? But So many doctors don't talk to their attorney throughout the whole case. So I recommend at least talking to your attorney 3 times minimum right after you get the case and you've evaluated them, to let them know everything you found. And then just part after the first re-exam to let them know how it's going with all these factors that you can support, where it's headed. And then toward the end, and all along the way, you are talking to them, not just letting them know what you can document and support from a permanency standpoint, what it's looking like, but also it'll help guide you on whether or not maybe you want to do the MRI now. In other words, it's now going to go past some financial limit or category. In other words, is it worth going there? So I highly recommend making sure, and also that communication with your attorney will be very powerful for maintaining that relationship and moving forward. So that's the 4 pillars of personal injury case management.